The Women's Self-Help Podcast is a place where women can go to find support, information, and tools they need to take control of their own health. We discuss the needs of women so you can become your own self-help guru. From how to manage your stress, eating for effective weight loss, real talk on self-image, maintaining lifelong health, and healthy aging, we cover it all. Be sure to visit womenssshh.com for more information on everything discussed in today's episode.
Hello and welcome to another episode of the Women's Self-Help Podcast. Today we are joined by Adrian De-Costa from iMove Physiotherapy at Miranda. Today we're talking with Adrian in the first of a three-part series on shoulder injuries, and we're going to be covering over these 3 episodes details about the shoulder joint, how the surrounding muscles work, types of shoulder injuries. We get into some research as well and talking about the difference between pain and injury, the correlation between those two, scans versus injury, and how come sometimes that pain doesn't actually correlate to the physical injury. We get to talking about common shoulder injuries, so things like bursitis, impingement, and tendonitis, and also some quick case study examples as well. This is a really great episode. I really encourage you to join in and listen to the 3 that we've recorded. This is the first part, focusing more on the shoulder joint. In the second 2 episodes, we talk in more detail about how it correlates to the back, about strengthening those muscles and keeping the shoulder healthy in the long term. So without further ado, enjoy this first episode with Adrian De-Costa. Welcome to another episode of the Women's Self-Help Podcast. Today, we are joined by Adrian De-Costa from iMove Physiotherapy in Sydney. So, Adrian, welcome to this podcast, and thank you so much. It's your first podcast, which is super exciting. A lot of the ladies here at KMJ are familiar with you. I've had you here to do a lot of talks, which is awesome. But for the listeners that don't know you, can you just explain a little bit about yourself and how you got into physiotherapy?
Yeah, definitely. Firstly, hello, everyone. So my name's Adrian, as Megan said. My background actually is exercise physiology with undergraduate work. So I did my Bachelor's of Exercise Physiology at UNSW a few years back now. I finished off my exercise physiology degree and just found that I was lacking in the ability to diagnose. I just wanted to take my education and my abilities and what I offer that step further. And that logical step was physio. So I then proceeded, I did my Master's of Physio in University of Sydney about 3 years ago now, and then pretty much been working at iMove since then. I was working at a few other clinics. So I was working at a clinic in Engadine, which is where I did a lot of my prac through uni, and I was lucky enough to score a job after I finished up. And then I was doing some work at another clinic in Bondi. It's a pretty funny story, actually. So the clinic in Engadine is where my mentors worked through, and obviously a clinic that I have a strong connection with still. And then I was working at a clinic in Bondi where I wasn't really getting much support and wasn't really the place for me. And it just so happened that iMove kind of came up at the same time. I had a friend who knew the owners at iMove, and they were looking to open up a new clinic in Miranda. And yeah, I guess the rest is history from then onwards. The beautiful clinic, great culture within the team. There's a team of 12 of us, and we have 3 clinics across Sydney. So it's an awesome place to work at.
Yeah, I think the great culture that you have with iMove is what makes it work so well when you guys collaborate with other movement practitioners. And I think you do a really good job of bridging that gap between, like you say, exercise physiologists and trainers, and getting everyone together in a way that really, really helps all of our clients together. And I know you've helped a lot of ladies at KMJ with that, which is why we're delving into these podcasts in about 3 episodes here where we're going to talk about the shoulder. So this is going to be the first part of a 3-part series on shoulder and different shoulder injuries that we're going to talk about. So would you agree? I mean, I find with the ladies here at KMJ that the shoulder is one of the most commonly injured areas of the body.
Yeah, I think I've treated a few ladies from KMJ, and I think it was last year sometime we did a talk, Megan, on shoulders itself. So yeah, it's definitely a very common area of injury, and with physio and the research out there, it's also a very limited area as well. There's a lot of good research happening now, and our views on shoulders have changed a lot from, I guess, the 1990s when you probably would have gone to a physio and, you would have probably have had an ultrasound machine chucked on you, or an interferential, which is the electricity with the suction cups. and that popped on you and left on your own. We've definitely gone away from that and moved to a lot more of an evidence-based way of treating. Having a base in exercise physiology in yourself and exercise physiology and strength and conditioning, it was definitely an awesome connection to work with, because we know now with a lot of the research that strength and movement has a key role to play in how we treat shoulders and get it better.
Yeah, I mean, when I look at the shoulder, I see it as, especially in the role between all the different practitioners, you definitely need the physios, so yourself and the guys at iMove, to do the diagnosis side of things, and then work with other movement practitioners as a form of treatment. So I see it as one being the diagnosis and the others being the medicine to go with the diagnosis in a way.
Yeah, definitely. I think you got to know what you're treating and you got to know the right approach. And then long-term continuation and management is crucial. I guess the best term to use is probably the use it or lose it kind of term. You know, you use your shoulder and you do the right things and it stays happy. You stop training or you stop doing things that were keeping it happy, and then maybe your shoulder that was grumpy 5 or 6 years ago might start to get grumpy again. Exactly.
And I think another way of helping that process along as well is getting the client really involved in their own treatment, which you guys do really well, and having that great open communication between the two of us. I know with a lot of ladies, it helps me keep on track of them as well. I'm constantly asking them in the gym as well, you know, have you done your exercises from Adrian? Okay, what did he say to add in before class? What have we got to do through? And I think making them accountable to that, but also getting them involved and understanding their body definitely helps in that kind of long-term healing process.
Yeah, I completely agree. I think ownership of your injury and understanding and having a great level of education, I think that's what we're going to be talking about today, just having an understanding of what the shoulder is and getting that educational component down. In fact, you know, both the education and the ownership of your injuries is crucial, because at the end of the day, if you're not self-motivated to get yourself better, that's a big barrier in the whole rehab process.
It is. And we're going to dive into that a little bit today. So we'll talk about, let's start then with the shoulder joint itself. So when we talk about the shoulder joint, obviously it's made up of the humerus, or for those that don't know, which is the upper arm. And then we've got the scapula or the shoulder blade, and then the clavicle or the collarbone. So can you just dive into the actual structure of the shoulder itself a little bit more so we can understand and paint a picture for the listeners there?
Yeah, definitely. So, I mean, as you mentioned, you've got 3 different bones there. So your humerus being your shoulder bone or your upper arm bone, your scapula being the shoulder blade at the back, and then you've got your clavicle. The shoulder bone is really unique in terms of the amount of movement you get. If you think about any, joint, it's the shoulder joint, not the bone, is unique because you get so much movement. You think about your hip, you think about your elbow, your wrist, your knee, and you don't get that 360-degree range of motion that you would at the shoulder joint. And the uniqueness comes with how this joint is actually structured. So the only bone in the shoulder that connects to your actual skeleton or your spine in some ways is your collarbone. So it connects through the front and then it branches out onto your arm. And then from the arm, the clavicle connects onto your shoulder blade, which is your scapula. And then those 2 bones have a connection, or what we call an articulation with the humerus. So shoulder being a ball and socket joint kind of gives you that girdle to work with and gives you that range of motion. But it's also super free because a lot of the shoulder in some ways is floating off the actual body itself and it's controlled by muscle movement. So to kind of put it all in a nutshell, you've got one joint that connects onto your skeleton, and then the other 2 are almost free flowing, but connected by a series of muscles that connect the skeleton to the shoulder blade, connect the skeleton to the humerus bone itself. So you've got big moving muscles, and then you've got a bunch of stabilizing muscles like your rotator cuff.
Yeah, well, let's look into the muscles a little bit more, because obviously having, like you said, that area that's floating around allows for that greater range of motion. So if we look at some of the surrounding structures that cover the bone, so the tendons and the ligaments, so to go through these structures, how we move the shoulder or how we work it through different planes of motion.
Yeah, so I mean, with the shoulder, it's important to know that, with any joint, we want to think about stability, and obviously the more stable your joint is and the better you feel. If we look at, say, for example, the closest joint similar to the shoulder is the hip. The hip has this really, really deep socket which the ball fits into, which makes it really stable. Then it's got a bunch of muscles like your glutes, your hamstrings, your quads that kind of all wrap around and give it that stability and that movement. When you compare the ball and socket joint at the shoulder level, you have a really, really shallow socket and you've got this big ball and gives you that big amount of movement. And there really isn't much in the way of ligamentous support. So ligaments being, I guess, the structures that connect two bones to each other and give a joint that stability. There really isn't much in terms of the shoulder. There's a few ligaments here and there, but in terms of the overall stability of the shoulder, it only contributes maybe 5 to 10% of the stability. So a lot of what happens in the shoulder is controlled by muscle action. So your biggest stabilizers in the shoulder joint itself is your rotator cuff. So your rotator cuff is a series of 4 muscles, 3 through the back of the shoulder blade and 1 sitting on the inside of the shoulder blade. And they work to stabilize the shoulder in different movements and also move it through a series of motions like rotation.
So can you just explain a little bit more about the rotator cuff then? Because that's, with the ladies I see at KMJ, that's been the area that the injuries have been occurring in most commonly. For me, with the ladies that I have, I tend to see it, in my opinion, originating from a lack of control through their scapula in some areas as well, particularly with overhead movements. What's your opinion on kind of that area?
Yeah, control in the scapula is one of those areas there's been a lot of research. We question, I guess, the quality of the research as to how good the quality might be. I think there's a lot of physios and a lot of people who probably overemphasize the importance of scapular control and really kind of bang on in that region and talk a lot about that. I think it's a combination of a few things. One is understanding the load a shoulder can take. So, for example, a lady that has just recently started training might not be able to load their shoulder as much just because they don't have that history and the muscles and the tendons haven't been subjected to that kind of weight and volume, and that needs to be gradual. So if they start to train and do a lot of overhead movements and traditionally haven't done anything at all, we find it's more so a combination of control just because their body doesn't know how to live in that position and move in that position. So that's where the scapula can come in, but also muscle tendon loading issue where the tendons are now being loaded a hell of a lot more than what they were loaded probably a week or so ago before they started training. And then you start to get this kind of rotator cuff related pain associated with it as well.
So in some senses then, is it more a coordination issue in that, say, for example, a lady that's just started training, rather than the actual, the 4 muscles that make up the rotator cuff being weak necessarily, it's just that their body is not accustomed to, or it doesn't have the ability to coordinate that overhead movement with that distribution of weight?
Yeah, for sure. It's a lot to do with that. So if you're starting to lift overhead, like I said, and you might find in the gym, you might have a lady and you're lifting them, getting them to do an overhead lift, and they just might not be utilizing the muscles through the shoulder blade, or they just might not be aware of the movement. So you probably see them trying to hitch or arch their lower back or really kind of flare out through their upper back to try and get that range of motion. So there's a lot of kind of motor cueing and things like that you'll be working on with them to try and get the right areas working so they're not overloading and compensating in different ways.
So if someone is having trouble balancing that load overhead or even a front-loaded movement or a lateral movement, how would you kind of cue them, or what's your opinion on the best cues to give them to kind of get their brain starting to become aware of managing the load in different planes of motion?
In terms of cueing, there's different ways you can do it. So you can work through with the person. You can really isolate that movement that you're trying to accentuate or you're trying to get them to get better at. So you can make it a really isolation-based movement where I could probably get them on the bed, either on their tummy or their back, and they're really trying to kind of work on that movement in terms of understanding what's needed of it. And then once they can get the control of that movement, say, for example, it's going overhead and then just not rotating their shoulder blade well enough. So I might just get them on the bed trying to learn how to rotate and understand that movement. I'll probably pop my hand in their shoulder blade and get them to kind of understand what I want them to do so they're getting that feedback through my hand. And then once they're getting that principle, and I'll start to load them up in that position, and once they're getting good, we can try and transfer a lot of those principles back onto the lift that they're actually having an issue with. So I'll start off on the bed, and then maybe after a few sessions, we'll say, okay, let's try and see if you can now get this happening in your overhead lift at a fairly light weight, and then gradually load that up again.
So if you have someone that, if we just take, for example, someone that isn't new to training, has been training for a while, and either the load has become too much for their rotator cuff and they're coming to see you with a specific injury, how would you then sort of incorporate, or what would you change with their training, working them back in, or any kind of warm-up specific exercises that kind of prep the tendon a little better? Or is it more a case of just progressing the load and then progressing it up again?
Yeah, there will definitely be a portion which is taking some load away, because we know the best way to get any injury to settle down is to kind of get away from what irritates it, but not too much in terms of having absolute rest. So rest is relative to what that person is doing. So for example, you're someone that trains 7 days a week, I'll say, okay, maybe let's look at maybe cutting out a day or two where you're giving your body a bit of rest to recover in between sessions. So we'll look at kind of deloading them in some ways or taking some load away. The other thing we'll work on is just understanding what movements they're putting their body through. So what kind of training are you doing? Are you lifting mainly overhead? Are you doing some sort of Olympic-based lifting, something CrossFit-based or functional-based? Which movements start to cause you pain? And then we'll start to really get into the shoulder and assess it for just normal range of motion, how much stiffness there is in the shoulder, is there a lot of muscle tone, what might be the factors involved, because as we've kind of gone through in some ways, the shoulder is made up of 3 bones and over 25 muscles, and they all play a factor. So there's not necessarily one thing that's causing it, but it's a combination of how all these things are working together in that person's shoulder that's going to make up history and the management.
And when someone obviously presents with pain in what they believe is the area describing the shoulder, there's a number of different pathologies or injuries that arise from the shoulder. So we'll delve into those a little bit. So, I mean, the most common 3, I think, would be bursitis, impingement, and tendinosis there. When you're going through a diagnosis, what things are you looking for if we go into bursitis first to determine if that's what the injury is?
Yeah, the thing with bursitis is it's rarely an injury that happens in isolation. If it did happen in isolation, typically the history will give us a good idea if, you bump on the shoulder and you have soft tissue bruising and it just feels, you get that tenderness right over a specific point. But it never really happens in isolation. And the way shoulders work, and I'll kind of deviate a little bit just to kind of give you an understanding of this and the listeners an understanding, is with shoulders, there isn't a specific point that will tell us pain is in that area. So with a lot of research coming out, and they're doing some great research at Sydney Uni and up in the UK as well, they're finding that the shoulder doesn't really, certain structures don't refer pain to a certain area. They have a really, really broad area of pain. So if you have shoulder pain, you can have pain from pretty much up into your neck down towards your elbow. So you can see how that's a really, really big area, and it's hard to kind of differentiate between one spot and the other. And going back to bursitis, you might have some sort of bursal or bursa irritation, but it's hard to determine whether that's the actual cause of the injury in terms of a direct injury to the bursa. So long story short, you can have some direct injury to the bursa, and that typically happens with some sort of trauma. If you've had a knock, if you've had a bit of a shoulder bump, those kind of things can irritate the bursa in isolation. But more often than not, the reason why the bursa gets irritated is because of its function. So bursa is a friction reducing structure. So it sits between a muscle or a bone or between 2 muscles, and it just sits in there to kind of reduce any friction in between muscles. So if your muscle is getting overloaded and you're not working it with the right kind of harmony like it traditionally does, the bursa starts to get irritated. So that's when we find most people with bursa injuries is because of an irritation due to load. And we get that mainly through the history.
So it's a symptom rather than a cause per se.
Exactly right. Yeah, I think the amount of people that come in and say, I have bursitis on their shoulder, and then the education is then to let them know that, yes, you do have an irritation of the bursa or an inflammation within the bursa, but it's not happening in isolation. There's a reason why your bursa is getting inflamed.
And what about impingement? So can you just explain about impingement and how that occurs?
Yeah, so impingement typically refers to the supraspinatus muscle. So the supraspinatus muscle sits at the top of your shoulder blade and passes through a small channel in between the shoulder blade and the collarbone and attaches onto the upper arm. So that small little passage can get smaller depending on whether there's an irritation of bursa or whether you're starting to lift overhead and not moving the shoulder blade efficiently enough. And then it starts to pinch the tendon and all the structures passing through that little passage. And that is predominantly what we refer to as an impingement in the shoulder.
And with impingement, what's the difference between, say, an athletic population and general population? So would you see it more commonly in general populations, or is that an injury that happens a lot with athletes or individuals that are doing a lot of high-performance sport type activity?
You can see it in both. So if you can see it in your everyday population where someone might be doing a few lifts with the wrong technique, possibly hitching the shoulder rather than really kind of engaging the muscles and rotating and getting the right movement through the shoulder, and then that can start to cause some sort of impingement-based pain. You can also see it in an athletic population. I think someone like a thrower, where they're doing repetitive amounts of throws through the shoulder, and then they start to get some sort of an impingement due to muscle fatigue or the loss of endurance in the muscle.
And with other injuries that are common in the shoulder, so obviously we've gone through bursitis and impingement. What about tendon pain or tendonitis? You mentioned before, obviously, that we've got those big tendons in the area, and when it comes to especially the shoulder work, I notice with the ladies, and I'm very careful to watch with people that are new to weight training, is overloading those tendons too soon. So can you just explain a little bit about tendonitis as well? So what exactly is it, and how does that occur in the shoulder joint?
Yeah, so tendinopathy or tendon-based pain. So we've gone away from, the tendonitis diagnosis or definition, because the itis in medical terms refers to inflammation, which we've found through research now that there is a little bit of inflammation, but not always. But it more so ends up being a disruption of the actual fibers of the tendon through the course of that injury. So the term you probably hear from now onwards with most, health professionals and things like that is, and for patients going to their doctors, they'll probably hear them say tendinopathy, although the tendonitis word does get thrown around because it's a more familiar term as well. But what we find with tendons is this is probably the main area where people are getting most of their pain. So the muscle is functioning ineffectively, and in essence, the muscle hooks onto a tendon. So your muscle attaches to a tendon, which attaches to the bone. So it's kind of the tendon is the link between the muscle and the bone. And if your muscle is weak, or if it's working way too hard than it typically does, the tendon starts to tug and pull, and it gets really irritated. And the tendons are super, super, super sensitive structures. So they love constant load and gradual increases. So if you load up in small increments in terms of if you increase load but then drop load and then come back to the same load again, it might not like you as well. So you've got to be really particular with how you load up the shoulder in terms of making sure your increments sit roughly between 10 or 15% per week.
And so with those increments, 10 to 15%, when you're talking about loading there, are you talking in regards to just the weight that you're lifting itself, or also the frequency of training?
I look at the 10 to 15% being a weekly amount of load. So both through the amount in terms of a session and the duration of a session, how often a week you're training, and also the weights as well, the actual weights. If you're lifting 10 kilos, you want to be kind of then progressing to somewhere around 11 to 12 kilos at the very most.
And with certain shoulder injuries as well, what's your kind of opinion if we talk about scans? Because you mentioned before, obviously, a lot of people come in and they'll say, like, I've got bursitis, but they haven't actually had any evidence to prove that they have that. Do you also see cases where someone may present with shoulder pain, but it's not showing up on any kind of scan, or the other way around, where something will show up on a scan and they don't actually have any resulting pain?
Yeah, so I guess there's two ways. We could go down one case, which is the type of patient that comes in and says, I have a tear in my rotator cuff, or I have bursitis. And we definitely take that into account, because when it comes up on the scan, there's obviously a level of validity because the scan can give us that information. But it always has to be married up with the history of that person. So if someone comes in and they were holding on to an 80-kilo trolley as they're going downstairs, and they've missed a step and the trolley's taken them for a ride and they've got a pull in their shoulder, they had an ultrasound and it says a tear, that tear is more likely to be attributed to that incident because it's quite traumatic. But where we see about 90 to 95% of people coming into the clinic with that kind of I have a tear in my rotator cuff line is they've been training for long periods, they're a bit older, probably about over 35, in that kind of 35 to 50-year-old kind of category. And they've gradually started to get pain through their shoulder, which is gradually getting worse and worse and worse. And what we find with these tears, it's more a degeneration of the shoulder. As you get older, unfortunately, the shoulder, your tendon, everything starts to degenerate. It's just part of aging. And that's where we find most tendon tears. And it's very likely that it's not the tear that's causing pain, but more so how everything is changing around the shoulder. That's probably causing a bit of pinching up or maybe a bit of irritation in the bursa and all the nerve endings in your shoulder that's causing pain. So there's really good research showing that where they did an MRI study and they compared people with shoulder tears. So they took 1,000 people and they found a certain percentage of people had shoulder tears and a certain percentage of people didn't have tears in their shoulders, but pain wasn't consistent. So they found people without tears to have shoulder pain and they found people with shoulder tears didn't have shoulder pain. So the question then goes to say, okay, the tear is not likely to be the cause of actual pain within the shoulder and there might be other sources where pain might be coming from.
So in those cases then, could it possibly be, you mentioned that you've got lots of nerve endings in there, they can also be irritated. So in that case, if they're not actually presenting with a tear in the rotator cuff, in the cases where they're still getting pain, could it actually be that that nerve ending or the brain is just sending a signal to the nerve to tell the body that there's pain when there isn't actually anything there?
Yeah, I mean, that's probably the $1 million question in physio at the moment with a lot of the research and the direction where research is going. That's what we're trying to find out as to what might be the more pain-sensitive structures because there's so many things happening within the shoulder itself. You can have a bit of bursal irritation, and we know bursa is a very sensitive structure. You can get pain from the tendon itself, so the tendons can be quite painful themselves. And then you've got a lot of nerves that go into muscularity might start to be quite sensitive as well. So in terms of which structure is the one responsible, I don't know. We don't have the research to back it up. But from my experience and from what I've read, I don't think there's one specific structure. I think there's a combination of a few things working together.
And do you see a difference between men and women as well in terms of the frequency of shoulder injuries as well? Like obviously the ladies that you see here from KMJ, quite a lot of them are sort of, early to mid 50s up into their 60s. Is that kind of the ballpark age group where you see these injuries starting to happen?
Yeah, I think that the degenerative shoulder, you can probably get that sort of pain happening anywhere from 35 years and upwards. It depends on that person's history. For some people, degeneration in the shoulder might start earlier. So, for example, if it's a lady who's, played competitive baseball or softball and was a pitcher and used their shoulder a lot through their youth, that shoulder is going to get degenerated a bit quicker as they age as well. Then you can get the flip, which is, I guess, someone who starts training a bit later in life just has your normal kind of wear and tear, and then that ends up being a wear and tear and a load issue through the shoulder.
And so would you approach the treatment differently then with those two different kind of backgrounds or histories?
In some ways, yes. I think, we'll look at the person and we'll say, what can they tolerate, what can't they tolerate? And it really depends on what that person wants to get back to as well. Do you want to get back to playing baseball or softball? Do you just want to get back to doing some general exercise? And that would determine it. Typically what determines how treatment initially starts off in terms of how aggressive we might be or how conservative we might have to be with a certain situation is typically pain. If someone's in a world of pain, we really want to settle that down. And if someone's in not as much pain, then we can tend to be a bit more aggressive and then monitor that and see how things are going.
And so then if you had someone coming, or say someone has shoulder pain, they're experiencing shoulder pain, how long would you recommend? Obviously, they don't want to wait too long before seeing someone, but what are the signs they should look out for where they should really definitely come and see a physio?
Yeah, look, It's an interesting one because where we see most people coming in is probably at a 2-month mark or a 6-week mark. And I think that's just human tendency. I'm sometimes guilty and I fall in that bucket as well, where as humans, we just put up with stuff because we just don't want to, go down that avenue, or we have other things that are more important, or we prioritize at the time. And then unfortunately, pain starts to dominate proceedings and then becomes a priority after a certain while. I always preach, and I always say, and research will show this as well, is that early intervention and the earlier you book yourself in with the physio is always the best, because you can really nip things up quickly. So that'll always be my recommendation, is the earlier you can get there, the better. So, if you're starting to get a bit of pain, and the things you want to look out for, what kind of movements are bringing on pain? Am I getting pain at rest? Am I getting pain with movements? And that would typically assist your therapist with understanding, okay, what might be happening. If it's a tendony pain, you'll notice that during exercise it's typically okay, but after you finish, it starts to get sore. That night it's sore, it might wake you up that night, and you might have a bit of morning pain and stiffness when you're going to brush your teeth or comb your hair, or when you're doing up your bra strap and just kind of grooming yourself through the day as well. So these are the kind of typical tendony-based symptoms that most people would experience, not pain typically during an exercise, but more so pain afterwards. However, you can get pain during as well, depending on how irritated the tendon is.
So if anyone's listening and they find that they're having some of the pain that you've just described, and they decide they want to come and see a physio, where can they find more information about iMove and yourself to start getting some treatment for their shoulder problems?
Yes, the great thing about what we do with iMove is we're really generous with our information, our exercises and things that we do. So if you follow us on Facebook, iMove Physiotherapy, or Instagram, iMove Physiotherapy, you'll find a range of exercises and mobility drills all the way from your shoulder down to your knees and your toes. And, you can start off just working your mobility, and if you increase your mobility, you might find that your pain might settle down, and that's great. You can always go to our website. We have a range of blogs and shoulders. I've written a few, and my colleagues have written a lot as well. The website is just www.iMovephysio.com.au. You can always also follow me. So my Instagram handle is itsmyphysio.adrian, and you can find me on that. So it's a little bit of a tricky one to kind of type down, but it's just itsmyphysio.adrian.
Perfect. Adrian, it's been so awesome chatting with you today. Obviously, we've just started to open the lid on the area of your shoulder. It's such a complex area, as we described throughout this episode. Make sure you stay tuned, because we're going to have part 2 and part 3 of this chat coming up with Adrian shortly, where we'll delve a little bit deeper into some other cases of shoulder pain and also more into the rehab side of things as well. So thanks so much for your time today, Adrian, and we'll catch up again soon.
No, it's my pleasure. I love sharing knowledge, and if there's any way where your listeners can communicate with you and have questions, and I'm happy to answer questions and kind of delve in a bit deeper into some of the stuff we've spoken about today in terms of, diagnosis and understanding a shoulder and the educational component of it.
Awesome. Thanks so much, Adrian.
Not a problem. Bye-bye.
Thank you for listening to another episode of the Women's Self-Health Podcast. I hope you really enjoyed this episode. It's been great speaking with Adrian. He has a wealth of knowledge about the shoulder joints and the injuries that can occur from that. So I really hope you got something out of this episode. If you enjoyed the episode, please head over to iTunes and leave us a review. We love to hear your feedback. You can also head over to our website, womensselfhealthpodcast.info. That's women's sshp.info. And if you love this episode, don't forget to also go to womensselfhealthpodcast.info/love and let us know. We'll see you on the next episode.